Welcome to everybody joining this MS Academy webinar on MS and COVID-19 and the coronavirus. Thank you all for joining, and we hope today will be informative. My name is Jeremy Hobart. I'm a neurologist based in Plymouth in the UK, and I'm joined by Ray Dorsey-Campbell, who is a senior neurology pharmacist from Imperial College, and Sarah White, who's a senior MS nurse from St George's Hospital in London. So just I think it's appropriate to mention the date. It is the 3rd of April, and the reason for doing that is that the information is as up to date as we can make it for today. But as you'll all appreciate, it's a fast changing field, and therefore we expect guidance and information to change over time, and I think that's something to be aware of. We hope that you will appreciate that this is an area where there is lots of uncertainty and perhaps no right answers to many of the questions that are posed, but we hope that the discussion will be valuable for you and provide you with useful information and support in your daily practice. And as of Wednesday evening, there were 1 million cases worldwide with over 50,000 deaths. And in the UK, as of 5 p.m. on Wednesday, there were 33,701 proven cases with 2,921 deaths. So this is a significant issue. So we thought that we would start by addressing some developments that have happened since the last webinar. And one of those is the updated Abn Guidance that came out last evening, 2nd of April. And Ray Dorsey-Campbell was on that committee. And Ray, can I hand over to you to tell us about the developments, please?
Sure. Hi, everybody. So one of the key developments in the latest version of the Abn Guidance, much of it remains the same, but the key change is regarding an additional line of guidance regarding blood monitoring of DMTs. So it was felt that that was something that was missing from the previous guidance, which outlines which drugs were felt to increase the risk or not of infection with COVID-19 and how to manage DMTs during this time. But there was a missing piece of information about how to manage the blood monitoring. We're obviously trying to avoid people coming to hospital as much as possible. So it was felt there was a need to try and give some guidance on relaxing the blood monitoring where that was possible. So that is the addition in the Abn Guidance, which is out yesterday, as you said. So what's been included is a table that summarises the blood monitoring requirements as required by the SPC or local practice, and then an advised relaxation of those. And very broadly speaking, the guidelines double the interval for most blood tests. So if it was a 3-monthly blood test, it's saying we can go to 6-monthly, 6-monthly blood tests to 12-monthly. There are some exceptions to that, so the cladribine bloods stay the same. There was some debate about teriflunomide and the 2 weekly bloods in the first 6 months, and a consensus view was monthly was good enough for that for the first 6 months, and then 4 monthly thereafter. And then probably the most sort of controversial is the right word to use, but the most contentious issue was the alemtuzumab bloods, and there was a decision that 3 monthly bloods was sufficient at the moment for patients on alemtuzumab.
Can I ask a question just there? I guess some of us are slightly concerned about that relaxation for alemtuzumab because the complications often present asymptomatically and very abruptly. So, for example, can really occur very quickly, and people can be left with minimum platelet counts. And I guess my concern might be that 3 monthly may be a little long, and I just kind of wondered what the discussions were from the committee about that.
Sure, there was a lot of discussion about that, and all of this guidance is preempted by a statement that wherever possible, the recommended monitoring should continue, and that this relaxation is only, in times when it's really difficult to get bloods for patients. The discussions there were a lot of people initially were very uncomfortable with extending the intervals of alemtuzumab blood monitoring, but members of the panel who had a lot of experience with alemtuzumab were giving some very reassuring feedback that in their experience that this was an okay thing to do. The two main arguments for that were a lot of the cases for things like renal failure and ITP had presented between normal monthly blood monitoring. So in fact, they had a normal creatinine on the Friday when they had the blood test, and then the following Friday they didn't. That was one argument about monthly blood testing is not perfect. And then the big argument about the ITP thing was that the most powerful thing was actually increased patient awareness to recognize signs and symptoms. And actually, as long as this relaxation came hand in hand with a strong reinforcement to patients about the things they should be looking out for, then that was an acceptable way to go.
Okay, so that's great advice. Now, can I turn this over to you, Sarah, because the people who are going to be at the coalface of implementing these changes are going to be the MS nurses. So from a logistical perspective, what does this mean for?
Sorry, you cut out there a bit, but I got the gist. So yes, you're right. The logistics of making all these alterations actually ends up with the MS nurses doing it. And so for our team, particularly for example, the Lemtrada patients, we already have a list of all the patients that are on the treatment. So it obviously helps if you've got databases and spreadsheets that are up to date. And we then made the decision that actually we were going to phone the patients, explain why they were going to 3 monthly. And to be quite honest, a lot of the patients are very pleased about that because they had already been voting with their feet and not coming to their blood test because they're worried about leaving home. And we also then took the opportunity to remind them of the signs of ITP and the things to look out for, and made sure they still had their Lemtrada booklets that they were given when they were first treated. And if they haven't still got a copy, we have posted them a copy with that information in it. So that's the approach that we took. And so I suppose it is about that self-awareness. And I think the other thing with a lot of the changes and things that have happened in this last couple of weeks is really to stop the routine work, to allow yourselves time to reorganise and sort some of these issues out, and you sort of prioritise the safety of patients first. And then hopefully we will get into a pattern of what we can and cannot provide at the moment.
Okay, so that the next, I guess, development that has arisen or has come upon us is the identification of people who are considered to be extremely vulnerable. So the backstory to this is that the government identified a while ago that there are 1.5 million people that they would be contacting as extremely vulnerable, who should be shielding rather than merely self-isolating or social distancing, etc. And so the chief medical officer circulated a letter last week, I think, that landed certainly on our doorstep over the weekend, was that actually the responsibility lay with us as the individual clinicians to identify people who were extremely vulnerable. Now, within that letter, they describe people on immunosuppressants such that they are at significant risk of infection, which of course is a terribly vague statement. And I know we've had a couple of questions in about this, and also about employment and people who don't meet criteria as being extremely vulnerable. So the first thing, and it's a question to you, Sarah, is what have you defined as being extremely vulnerable, and how have you gone about identifying and contacting people?
So we used our database. If services haven't got a database, then you would literally have to go through your patient caseload, I suppose, one by one. And we decided that it would be very difficult to identify everyone with a respiratory issue or that was being peg fed. because it would just be so time consuming. So we took the decision that if a patient had an EDSS of 7 or above, that they would fall into the shielding category. And the chances are that a lot of those would have respiratory problems or be peg fed or whatever. We've also included those that have received Mavenclad or Lemtrada within the last 12 weeks, and patients that are on more than one immunosuppressant, which obviously for MS patients is very unlikely, but there may be a few.
And Ray, from the aspect of the drugs, what's your view on people who are extremely vulnerable? Should we be using lymphocyte counts to identify people?
I missed the first half of your question, Jeremy, but I think you were saying in terms of patients on drugs, how would we define extremely vulnerable?
Yeah.
We would just be following the guidance that it is those patients who've had alemtuzumab or cladribine in the last 3 months that are the most vulnerable. And we haven't looked at lymphocyte counts. We haven't gone through and looked at people who are lymphopenic, but what we are doing is, in the way that we do anyway, is screening our prescriptions for checking now that we're relaxing the interval between tests to see what their lymphocyte counts have been, so that we can identify those who may have had a more persistent lymphopenia, particularly if we're not going to be testing them for another 12 months, then we would need to be more careful about them.
Yeah. So just to add there, we've identified anybody with a lymphocyte count below 800 as being more vulnerable, and we've included them in our conservative idea of people who are extremely vulnerable, and that includes people on DMF and also people on fingolimod, although we recognise that there are contentious issues around both of those two drugs. And likewise, in terms of the more disabled people, we too have taken a cutoff of an EDSS of 7, implying that people are likely to have some respiratory or bulbar involvement, and therefore they're likely to be in the more vulnerable group.
Jeremy, coming back quickly to the lymphocyte counts, just to say, I know that's always causes questions amongst people about what a lower count is acceptable, particularly on Tecfidera. And there was in the guidelines, when we talked about, we specifically mentioned a level of 0.5 for dimethyl fumarate, that a 6 going to 12 monthly was acceptable as long as their lymphocyte count was above 0.5. And that did cause a lot of conversation, because like you, a lot of centres around the country use 0.8 as their lower cutoff. So the outcome of that was to leave it at 0.5, but that doesn't stop local centres using their own, what they're comfortable with, which is 0.8 in a lot of cases.
Yes.
And Jeremy, can I just add that the list I gave you was for shielding.
Yeah.
So for self-isolation, which is obviously only one step down from shielding, then we have a much bigger group of people that we have put into that category, which would include those that have a lymphocyte count of below 0.8.
Okay. Okie dokie. So there are a couple of other developments that have been circulated, and then we'll come to the specific questions that people raised. One is a publication that has come around about vitamin D deficiency increasing the risk of COVID-19 infection and a more severe course of the illness, which I guess from an MS perspective is comforting, given that we generally recommend that people should be on vitamin D supplementation. That's not published, but it's in the public arena. And the second thing that may be of value to people is the minutes of a meeting around COVID and MS that was an international meeting with over 120 attendees from all sorts of countries. But there was some interesting information that came out of where they have an ongoing study, and their comments were, so far, based on the data they have, their view was people who were lymphopenic did not seem to have a worsened disease course. And the overall summary from that was that there appeared to be a cautious consensus that it doesn't look like COVID-19 is more frequent in people with MS on DMTs versus those who are not on DMTs. Now, obviously that's emerging information, but I think that is comforting for us. So let's now move to the questions that we have had in, and the first two, I guess, are around the same concept, which is how do we deal with people with acute relapses? So Ray, can I ask you to comment on the use of steroids in people with MS relapses?
So we high dose IV methylprednisolone does put people at risk of infection, as we all know. So we would not be advising people to use high dose steroids unless absolutely necessary. So our centre is obviously, we're avoiding bringing people in for IV steroids, and only using a course of oral methylprednisolone in really severe, clinically severe relapses. With just trying to reassure patients that the point of steroids is to speed up the recovery from a relapse, but it won't change the outcome. So our advice is to avoid steroids at all costs at the moment. Okay.
And any comments about plasma exchange?
Not something that we've used, or not something we have very good access to. I think that would be, well, there's two limiting factors about that, is access to plasma exchange, and also it's quite an invasive inpatient procedure, yeah, which at the moment I think is not a wise thing to do unless you really have to.
Yeah, and I guess the other thing in relation to relapses is that if people have significant relapses, then there may be a case for escalating their treatment. And the recommended high potency treatment, Ray, at the moment is
natalizumab is the one that we're recommending to be the best option for people. But that comes with its own challenges at the moment in a lot of centres. Actually, the capacity to infuse safely is becoming an issue.
Yeah, and that actually takes us on to a couple of other questions in and around the Tysabri scenario, which is about extended interval dosing. And the specific questions that we have are: do you think there's enough efficacy data about extended interval dosing to prescribe it to every patient under natalizumab to reduce the potential of COVID-19 infection? And because of the risk of high PML risk, for which ones would you propose extended interval dosing? So Ray, again, what's your current practice on extended interval dosing at the moment?
Well, it's interesting, isn't it? Because we had to answer the question about evidence if there's efficacy, we all know that the evidence is minimal around efficacy and that there's ongoing work to look at the efficacy of extended interval dosing. There's some suggestion that the PML risk is reduced, and it is stated in the drug SPC that it's an option, although it's not. There isn't good trial data to support that practice. Our centre wasn't routinely using extended interval dosing. We have a large number, 300 plus patients on natalizumab, and we haven't been routinely using it. I know a lot of centres do switch their patients to extended interval dosing routinely at 24 months, and other people use it just for their high JCV patients. It's not something we were doing. I think the question about the data to support using it in everybody is a bit of a moot point at the moment, because I think people are just not going to have the option to infuse everybody monthly, and we certainly don't. So we're not able to infuse anybody this month at the moment. We're working on ways to get around to find a safe space to infuse our patients. So there's two answers to that question. No, the evidence probably isn't strong enough to recommend it for everybody at the moment in normal circumstances. However, these are not very normal circumstances. I think everybody should be moving to extended interval dosing to help keep people out of hospital.
Okay. And Sarah, what's the experience at St George's around Tysabri and extended interval dosing?
So we have a small number of patients that are already on extended interval dosing, but to 6 weeks. And our plan is, because we're still infusing our patients at the moment 4 weekly, but we have had to move our infusion to a safer place within the hospital, and also take over infusing patients with different conditions as well as a team, to allow those staff to be redeployed. And so we've got less capacity. And so the decision has been that actually all our patients, unless there is a specific reason why they can't, or the consultant doesn't want them to, are going to go to 8 weekly, because this will, the consultants had a lot of discussion around this. And from a practical point of view, if you go to 6 weekly, it just becomes more difficult with all the scheduling. Whereas with 8 weekly, it means essentially you're doubling your capacity, and makes it easier when this is all over to get them back onto 4 weekly again. But we've made the decision for new patients coming onto treatment that they will have 3 or 4 monthly infusions before we then put them onto extended interval dosing. And bearing in mind that more patients are going to become eligible with the relaxation of who is eligible for Dorsey through the new guidance that's just come out, we're going to need to make sure we've got capacity to treat more patients at the moment. And so to make sure everyone gets some Dorsey, that's the decision that we've made.
Okay. And the reasoning behind 3 to 4 monthly infusions before moving to extended interval dosing was around what issue? Was it around disease control or neutralizing antibodies?
It's probably one for the consultants, but I think it was more about getting disease control and giving them a few the 4 weekly infusions to start with, to help with the efficacy.
Ray, any comments about the 2 issues there that I'd like to pick up on? One is a kind of starter pack of 3 to 4 monthly infusions, and the second one is 8 weekly infusions, because I know this is something that has generated discussion.
I think it would be sensible to give somebody monthly infusions to start with, from the point of view of, these are patients that are highly active disease. Like we said, the strong data to support extended interval dosing is not really there yet. So we would probably look to where we could infuse people monthly in the first 6 months. But having said that, we're not able to do that. So we'll be going to extended interval dosing for everybody from the start. And I've forgotten the second half of your question already, Jeremy.
The second half was any concerns over 8 weekly rather than 6 weekly.
Yeah, so there was a lot of discussion about that. And initially I was very much for the evidence is for 6 weekly, and it's not really there for 8 weekly, and we should be going for 6 weekly where possible, because that's what's recommended. But like Sarah says, from a practical point of view, we're having to move away from like best clinical practice to best practical clinical practice, and 8 weekly is going to be much easier for everyone to manage in the current times. We will do 6 weekly where we can, but I think it's becoming out of necessity that we're going to have to infuse people 8 weekly.
And we have the same issue. Weekly is so much easier for the scheduling. 6 weekly does create a real scheduling headache for our service coordinator.
Unless you've got some clever scheduling software, which is out there.
Is there?
Yeah.
Available too, so that people can access that from the Academy website, or is it already there? Maybe.
I can get the Academy access to that, but there is some software out there which some of the pharma companies are supporting. Yeah. Okay. Which does make scheduling for everything a lot easier. Okay.
Now, on the concept of extended interval dosing, there is a question around ocrelizumab and concerns about delaying subsequent doses. And there are issues around how long. The questions are around how long is reasonable. And are there concerns around neutralizing antibodies? Again, I guess that's one for you, Ray, in terms of the.
Yeah,
the
I don't
drug.
actually have any experience or know much about neutralizing antibodies with ocrelizumab. It's not something we've been involved in to date, but we certainly have had a lot of discussions about the second and third dose patients. We at Imperial have been routinely collecting B cell counts off everybody from day one. So although that's not required in the SPC for ocrelizumab, we, for research purposes, have been doing that because we're interested to see what the effects on B cells have been. And I see patients coming back in my clinic for ocrelizumab prior to their 6 and 12 monthly infusions, and consistently the B cells are still really, really low. Everybody's have been sort of below 10. Well, we should be looking at a percentage rather than the number. We've looked at this a lot, and I know one of the questions on the list that came through earlier, which I'll bring in now as well, was regarding rituximab. So the obvious place to look for information on this is to rituximab, because it's been around for so much longer, and there's practice embedded in managing rituximab infusions. If you look to the NMO group, and there's also questions about NMO on the list, the NMO groups in the Walton and Oxford look at percentage B cells before they redose people with rituximab for NMO. And as long as they've had a number of infusions, so 2 or 3 infusions, they would then look to would not redose unless the percentage B cell count came above 1%. Yeah. So I think it's reasonable. There's 2 things here. I think you can have good confidence that if you've had at least 2 doses of ocrelizumab, your B cells are going to stay down for much more than 6 months, in my view, because everyone I've seen so far has had persistently low counts. So we can reassure patients that the drug is still acting, even though we're not giving it to them. And our recommendation to our patients is not to come in for a 3rd or 4th infusion at the moment, but to wait. If you had the luxury of being able to measure everybody's B cells, which you can't do at the best of times, but at the moment is even harder, you would wait till they started to drift up before you would redose them. And that would be my advice, is not to redose people, and have some confidence that their B cells are low enough.
And my understanding from the rituximab data is that there are there's a considerable cohort of people who have had single dose rituximab and have remained well for longer periods of time. I guess one of the positive sides of this pandemic is that we will gain interesting information about the longevity of the effect after single or shorter dosing schedules. So there is, you mentioned NMO, and there is a question about delaying rituximab infusions with people on NMO. And I wondered if you have any specific comments about that.
So coming back to what I mentioned before about the big NMO centres do have, as far as I'm aware, and I have been in touch with them previously, use this approach of monitoring B cells and waiting for them to come up, start to drift up. And they do, for people who've been on it for a long time and that are stable, increase the interval between rituximab to sort of 9, a month at a time. So 6 months, then to 7, then to 8, then to 9 is their approach. But having said that, we all have patients that we know who are particularly at risk of relapse and of having problems if their doses are not given more consistently. So it's a bit of a case-by-case thing, I would say. But overall, I would say it's okay to delay rituximab in the same way that it is ocrelizumab, but taking into account when they last had their dose, because if they've been on it for a long time and their last dose was 12 months ago, then that's a much longer delay for them. Yeah.
Okay. Just to add, I did look at the NMO UK website on this, their guidance, which was actually written quite a long time ago now, so it looks like it hasn't been updated in the last 2 weeks or so, was that people shouldn't stop their Ritux infusions if they have NMO as a diagnosis. But again, it is an evolving field of understanding. So if we move on to further questions.
Jeremy, there's also questions on the Q&A that might be relevant to the things that you're discussing at the moment as well.
Okay, I'm going to pick up on those, but I want to bring Sarah in on a question that certainly from a practical perspective we have had quite a lot of, and this is saying we are getting an increasing number of requests for letters to employers to endorse 12-week self-isolation for people with MS in the absence of the shielding letter from the government. Do you know where we stand with this, or what recommendation you would make?
Well, I mean, I think it's important to support our patients as best we can at the moment, because you know, a lot of them are obviously feeling very anxious, but mindful also that some centres are really struggling. They've had some of their nurses redeployed, and so they're running on a very reduced service. At the moment, if a patient is phoning and their employer is specifically asking for a letter, then you know, if they fit into the category of self-isolation, because obviously not everyone does, then we would support that with an email to their employer or a letter. I think in my experience that really hasn't happened very much. It's been a few, it's not been a lot. I think a lot of employers are beginning to get it, that you know, you've only got to listen to the news in the evening that's promoting people staying at home. So in our experience, it hasn't been a large group of people that we've had to do this for.
Okay, so I'm just going to pick up on a couple of questions that have come in while we have been discussing, and one says, and I think this is covered a bit in the ABN guidance, Ray, so I'm going to back this to you, is if patients are suspected of having COVID-19, should we stop their DMTs?
So yeah, this came up recently in our service, actually, because there was some confusion, but people are some people are choosing to stop their own treatment, but the guidance from the ABN guidance talks about people with active COVID-19 infection, and it says we recommend stopping all injectables and oral medication and delaying infusions. But then it goes on to talk about restarting if they've had negative tests 1 week apart. So clearly, the spirit of this is for people that are admitted and tested as COVID, is how we've interpreted that. If people are admitted and tested and positive for COVID-19, it's very reasonable to stop their immunosuppressive treatment. If they're at home with mild symptoms, we would say not to stop their treatment, because as we know, particularly with the first line sort of injectables and teriflunomide and tecfidera, the risk of infection is not considered to be greater, and actually stopping your MS treatment might be more of a risk to you than continuing the drug.
Yeah, that was my understanding, is that you keep going unless you're really sick.
Yeah.
In simple terms. So there's another question here about that I think we've covered, but just so that it's clear that we have, is about the phlebotomy service for Lemtrada patients. Can we do 2 monthly monitoring instead? And you can. The ABN guidance enables you to go to 3 monthly if you wish. So that's positive, I think, for you, and I hope that answers that. So here's one on cladribine, because cladribine is obviously one of the considered to be more concerning drugs, although that's debatable. How would you describe the level of COVID risk for people who have taken cladribine, e.g. 6 months, 12 months, or 2 years ago? What do you say to that, Ray?
I say that unless you've had it in the last, going by the guidance, unless you've had it in the last 3 months, that your risk then becomes, in my view, moderate, and compared to, it's as per the other drugs, is what I would say. If your lymphocyte count, and again, looking, like you said, looking at lymphocyte count, although it's not thought to be an indicator, you obviously, in the initial phases of treatment, when you've got low counts, you're more at risk. Somebody who's 6, 12 or months longer down the line, in my view, is no more at risk than the other first line therapies. Okay,
Sarah, any thoughts?
I completely agree, and that's the advice that we're giving to patients.
Okay. Yeah, somebody just commented here that we have asked patients to copy the letter re-shielding that we've sent to them and sent to employer. I think that's perfectly reasonable. I think if you've received a letter, then people have that, and if you send it by email with a covering email, then actually that's even better. They've got that to take as well. So there's another question here on teriflunomide. And someone asked, antiviral effect of teriflunomide benefit the pandemic situation? Now, I guess what I have seen discussed is there may be a benefit from teriflunomide, but it's far from clear. Ray, do you have a view?
My view is that it's not that the antiviral effect is not clear, and I would be reluctant to advise that was helpful. I mean, we're advising, as we've said, to continue teriflunomide for patients on COVID. So I mean, if it turns out to have an antiviral effect, that's a benefit. But I don't know enough about the antiviral effects of teriflunomide to make a recommendation on that.
There's another question just back to the Tysabri issue and extended interval dosing, because I've seen comments about this. Is there any relation to body weight? And is there a cut-off body weight for 6 or 8 week interval dosing? Now, I think one of the issues that we have discussed here is that the driver for this is largely going to be the logistics and the actual practicalities of what we're able to achieve, let alone do this. But I know there's been some discussion about body weight. Has that come up in the kind of discussions around Abn Guidance, Ray?
No, not that I'm aware of. It hasn't. So I know that there is some data that the larger body weight. I've got to get this the right way around now. That the larger body weight require a shorter interval.
Yeah, that's what I've seen as well.
Yeah.
I've seen that. I think Gavin's written on this on one of his blogs, that there is some suggestion that if your body weight is below 60 kilos, then going to 8 weeks is probably fine. But it's unclear.
Yeah, I find that very difficult to understand, given that it's a large monoclonal antibody protein that's blood bound. It would be, your body surface area. It would just more than your actual body weight. I think that would need to be considered there.
Yeah. So here's a nursing-based question for you, Sarah. Has anyone had any experience of any incidents of PEG insertions being cancelled because of the COVID-19 pandemic?
I haven't as yet. I can understand that might happen, but as yet, no, we haven't had it. I mean, I think you have to balance all these things up about the risk of someone not having a PEG, but either if it's come out or if they require one, you have to balance up the risk of them aspirating or not getting enough food and fluid by other means against having the PEG inserted.
Okay. There's another question on the, which I think is in your ballpark, Sarah, again, is my concern is that many of the patients with EDSS 7 or above have carers going in all the time. Any advice here?
My understanding is that all the care agencies have given their own carers advice about being careful, so hand washing, gloves, all the obvious advice that you should be giving when you're caring for someone. There is no way around it. If a patient needs care, they need care, and therefore it's more about using the right techniques when you are caring for those people. It obviously is of concern, but they need care. They need looking after.
Okay. There's a question from Davina Paling, a first-year nursing student in Sheffield. If someone has had 1 week of cladribine, would you give them their second week's course after 1 month? Ray?
Yes. So we talked about this on previous Q&As, and My approach to cladribine is that if you've started it, I've started so I'll finish, so to speak, in terms of the first each year's course. If you've given them 1 week, they're already lymphopenic, they're already, the action of the drug has already started. And if you're not giving them the second course a month later, you're not completing the course and doing and fully treating their MS. So we had exactly this scenario. A lady had her first week in February, and then the COVID information hit, and she was concerned about having the second month. But we went ahead and talked to her about that, and with her consent, we carried on and gave her week 5. If somebody's between year 1 and year 2, we wouldn't start the year 2 course, but we would complete 1 year's course.
Okay, so on that, we had a situation where we tried to intercept someone starting cladribine, and they'd taken 1 tablet.
It's tricky, isn't it? That becomes a cost issue then. Very expensive tablet.
Yeah.
And, but I mean, I think if they did, of 1 tablet of week 1.
1 tablet of week 1 of cycle 1.
Yeah. And were they, there's so many questions. Were they treatment naive? Were they highly active?
Yeah. No. Treatment naive, highly active.
And they're going, I'd tell them to go for it and stay at home.
Okay. We told them to stop.
Did you?
And we're going to stick them on Tysabri. So,
I
guess, yeah. I guess these discussions are around what has happened in practice in situations where we do not know necessarily the right thing to do.
No.
Next question. And I guess this is focused for you, Sarah, I think. If patients consent, knowing the risk, and are eager to have their subsequent courses of ocrelizumab at the given time points, are we happy to proceed, firstly? And secondly, should they self-isolate or shield?
I think, and certainly in our centre, even if patients are happy to consent, I think they need to take the guidance from the people that are the prescribers, because they obviously have the medical knowledge and understanding. And so far, we haven't treated anyone with ocrelizumab, either starting them or giving them their subsequent dose since the COVID crisis started. So even if the patients are happy, patients are anxious and they're worried about relapse, understandably. So I think it would be more about counselling the patients, looking at the alternatives, rather than just because they're happy to have it, that you go ahead and have it.
Right.
Well, we have had this scenario. So up until very recently, we were still giving people who wanted to, having understood all the risks, who wanted to continue. They were coming in until just a couple of weeks ago, having their 2nd and 3rd doses. That's changed now. We're not able to do that for people anymore. Like lots of people do vote with their feet and just don't want to leave their homes and come in, don't want to have further immunosuppressive treatment, especially if you reassure them about their B cell counts. But we have had a couple of patients who were very insistent that they understood the risks and they wanted to proceed. And we allowed them to do that when we had the capacity to do it, which we no longer have. And in terms of shielding, it's self-isolating and social distancing with ocrelizumab, unless they've got other risk factors, that are such as comorbidities or age, then they wouldn't need to shield. They just need to stay at home and self-isolate.
Even in the early stages, because there was a suggestion, I think that was in the first draft of the ABN guidance, which came out about the 11th of March, was that people were higher risk within the first 3 to 6 months after their ocrelizumab infusion. Now, I know that's been considered somewhat debatable, but your view?
I can't understand the logic there, because the action of the drug is to deplete your B cells, which it starts doing as soon as you start infusing it, and peaks within a few days. Your B cells are gone certainly within a couple of weeks of having ocrelizumab, as far as I understand it. And then, so your risk is there as long as your B cells are depleted, regardless of how soon or long ago you had the infusion.
Yeah. So on the answer to that question, I guess from our perspective, yeah, if we have capacity and people consent and we feel that they are fully aware of the circumstances and have been given alternative opportunities, if that's what they want to do, then I think they should be allowed to take that risk. So that's the first thing. And secondly, yeah, we'd advise them to be really safe. So I guess the issue about self-isolation and shielding and to what level you go is the higher the level you go, the safer you will be. And whether you should have these binary cutoffs have been, well, you should shield or self-isolate or what have you, I think are harder to create. Okay, next question. Next question. I think we've done most of these. We've done most of these. We've talked about swallowing, or increased number of requests. We've talked about steroids for relapses. We've talked about blood tests. So someone's asking, is anyone undertaking blood and urine testing during relapses? I guess they would be.
I presume they mean urine dipstick testing. I'm not sure what the question means, but I mean, not currently. Is anyone?
Yeah.
Yes, I mean, if you're concerned somebody has an infection, you would still have to access, urine dips or blood tests if that's relevant. Yeah. Well, obviously we're guiding people to their GP for that because we don't want them coming to hospital.
Yeah. Okay.
There's also the dip UTI that you can get from the pharmacist as well at Boots, and the pharmacist can actually do the results, so you don't have to go and even see your GP.
Yeah, and I think it's sensible. I'm sure Sarah would agree here that we still use we still dip and grow things in our urine, and we don't just give everybody antibiotics.
No, absolutely, and then because a lot of patients can get someone else to take the sample to the GP if they haven't got access to going to the pharmacy. So, but yes, that is definitely what we're doing. And also to rule out if someone's phoning in with new symptoms that they think might be suggestive of a relapse, to rule out they actually haven't got an infection first.
Yep. So here's a good question. Could you offer more clarity re-shielding? For example, vulnerable bed-bound patients who do not have swallowing or diagnosed breathing issues, but in my opinion would be considered appropriate to shield, who do we escalate it to? So I guess my view on that would be, we have been tasked with the opportunity or the issue of identifying people who we believe are appropriate to shield, and if we feel that shielding is appropriate, then we can advise them to do that and send them the government letter. And I think these are the kind of grey areas of clinical decision making. Sarah?
Yeah, absolutely. And as I said at the beginning, we have defined the category of shielding to include all those with an EDSS of 7 or above. So if you're bedbound, you will have an EDSS of 7 or above, and therefore they would fall into that category. And I don't think no one's questioning our judgment about who we're putting into that shielding category, so put them in there.
Okay. Ray, anything to add?
No, I think you're right. It's a clinical decision. If we have specific patients that we think are at risk, then it falls upon us to highlight those patients. We're not routinely offering people letters from our service at the moment. Our nurses have been redeployed and we don't have the capacity to deal with all those requests. But certainly if there were particular patients that we felt were at risk and needed our assistance, we would obviously do that.
Okay, next question. Would a person with mild MS and mild asthma be at much greater risk and shielding be applicable? Sarah.
Well, we've had that question,
Right.
Sarah. Sorry, go on, Sarah. You go. Well, I was just saying, my response was to refer people back to the guidance, which is having MS in itself does not put you at risk. having a long-term respiratory condition does, but whether you consider mild asthma to put you at risk, I think is a question for the GP.
Yeah.
Yes, I mean, it's one of those grey areas again, isn't it? But you know, if they have another condition like asthma, however mild it is, you know, we will perhaps be suggesting that they've put themselves into the self-isolation category. But you know, guidance from the GP is probably quite difficult now because it's very hard for patients to get through to the GP, in my experience. So I suppose we'd always fall on the side of caution. You know, if a patient's phoning in with that, I don't know what they might be describing themselves as having mild asthma, but I don't know about their asthma. And so I think we'd always go with being on the side of caution.
Okay. I mean, I would side with you both. I think mild MS and mild asthma, assuming that mild means mild that we believe, I wouldn't have thought shielding would necessarily be a requirement for them. Okay, another question. Would you start fingolimod during COVID-19? So I guess that's mean during this pandemic. Ray, this is a drug-related question.
So yes, in terms of the risk to the patient of getting COVID, we know it does put you at risk of viral infections, but if you're eligible for fingolimod, it's because you've failed a first-line treatment and you need something else. It's not an infused therapy, so it's keeping people out of hospital in that sense. However, getting someone in to do first dose observation for fingolimod at the moment, my trust, is a non-starter. So from a drug point of view, I would say I would be comfortable starting someone if it was needed for their MS, but from a practical point of view, it's not going to be possible.
Okay. Another question, MRI monitoring for Tysabri.
So this, when we did the ABN consensus on the monitoring of the bloods, MRI monitoring was discussed a lot in those discussions. And it's another thing about it's not what you want to do, it's what you can do at the moment. A lot of people were managing to still get scans for their high positive patients around the country. Routine MRIs are not happening in our trust. We're only allowed to do inpatient and urgent MRI requests, so none of our patients are being scanned at the moment, even our high positive ones. So it's very much what the service can manage, but the bottom line should be, I think, that we should be scanning our high positive patients still.
But probably less frequently. Because that's what we're going to logistically. So you could, I mean, I guess in some ways that what we have done is people have been routinely imaged, but they may not have necessarily been seen clinically. Whereas now maybe the emphasis is on a 3-monthly contact rather than a 3-monthly scan or a 6-monthly scan, depending on people's criteria. But again, that's going to be a logistical issue based on what happens to your service, whether you've actually got any people left, given the deployment issues that are happening.
But I would say for Tysabri, if they are still getting their treatments, even if it's 8 weekly, they at that point are having contact with the service, and so just making sure that you're really doing a really good pre-screen each time is very important.
I think that makes a lot of sense. So next question, when do you feel we will be able to restart ocrelizumab and natalizumab infusions as normal?
That's Davina again.
It is.
How long is a piece of string? we just don't know, do we? I just don't think we know at all. No. I don't think you can plan. I think we're telling patients that we simply can't say at the moment when things will be back to normal. If we're flattening this peak of infection and our hospital remains at capacity while we do that, then we're going to push the date for restarting further away because we're filling up with COVID patients. But I'm going to punt it a couple of months at least.
Yeah, that's kind of what we're banking on. 3 to 6 months is kind of what we think we're looking at, but I guess we'll know more next week and the week after, etc. So here's one, and this is an important issue for you, Ray, because this is about delivery of DMTs.
Yeah.
Home delivery services are not delivering new treatments. Therefore, can you start people on new treatments? So can you kind of update us on what the issues are about treatment delivery? And I guess more to the point, what do people do when they run into logistical problems?
Yeah. So what we have to remember as an MS community is that the home care delivery network is much wider and much bigger than MS. So the home care companies, there are limited numbers of them nationally, and they're delivering to thousands of people with a range of conditions, including, hematological conditions, cancers, rheumatoid, all sorts of reasons why people have home care, home TPN in some cases. So the companies have to prioritize groups of patients who are more vulnerable and more in need. Second to that, there are a limited number of companies, and we know that their capacity is fragile. We've had instances in the past where home care companies have gone under, and that leaves a lot of people without delivery of their medicines. So there's a national group of people that look at this very carefully to spread the workload around multiple home care companies to make sure that we're not reliant on one of them only, and that they're working within their capacity. Because we can't infuse people at the moment with MS, if we were to move everybody to oral or injectable drugs by home care delivery, the home care companies simply wouldn't cope, because as well as us doing that, we have other specialities. So for an example, tocilizumab IV is being kept in some centres for potentially treating the cytokine storm around COVID patients. And so patients are being asked to move on to subcut, and they can't do that either because they're considered new home care work. So it's a much bigger picture, and I think it's the right thing to do actually at the moment, not to start new home care therapies, because we need to protect the services that are already out there. What we can do about that is a harder question to answer. We at Imperial don't actually use home care for our oral treatments because we have an on-site community pharmacy, and the patients we're collecting from us, we're actually set up our own sort of delivery service from the pharmacy. So we're delivering, couriering medicines from the pharmacy to patients' homes. And I think that's probably the only thing people can do in the short term.
Okay.
Can I answer? Can I
Yes,
come
please.
in there?
Please do.
So we've obviously had the same issue as everyone has. Like Ray, we are going to use, we normally use home care for delivery, but we're going to use our own delivery service to deliver. So for patients that need to start on orals or injectables, they will be delivered. We then obviously also have the added problem of how we're going to train patients in how to give injectable treatments, because we've been using the home care nurses to do the training. And so we're considering two options. One is to provide that by our reduced nursing team, because some have been redeployed, but to provide that either by video or to bring them into an area of the hospital. It's actually a porter cabin, so it's not into the main hospital, to treat them face to face. And we'll give the patients the option of doing either or. And so we haven't quite got together our crib sheet yet for training, but once we have, I'm obviously very happy to share that with the nursing community. And probably the easiest way for me to do that is through the UK MSNA.
And just to say, Jeremy, sorry to interrupt you, but on the home care issue, all hospitals were sent this week, and actually the deadline for it was yesterday. But I'm sure if you speak to your pharmacy teams and you've got concerns, they can send it on your behalf. We're sent a list of therapies that their hospital would like to be able to start and predicted numbers. So the home care community are looking at what the numbers are. So if you have if you want to start a handful of patients on interferon a month over the next few months, speak to your home care pharmacist about making sure that you were included in those numbers.
Right. Are the pharmaceutical companies able to help here in terms of delivering or organising delivery of their drugs?
So the pharmaceutical companies have to have an SLA with an approved home care company, and setting up new SLAs is a torturous process that involves a lot of governance. So I'm not sure that they're going to be able to help within existing frameworks, but they are very keen to help at the moment. So it's worth having a conversation with them about what other things they can do to support you.
There's a work opportunity for setting up a home care delivery company. 2 more questions, if we've got time to go through those.
Yes, you've got time.
Thank you. So one of these is, have you observed any interactions between specific treatments for MS and the COVID-19 treatments that are being proposed, such as hydroxychloroquine and all the others? Ray, that's got to be yours.
I was looking at that question, wondering when you were going to read that out to me, because no, I don't have any. I haven't observed any interactions. I'm not aware of any. I think the number of patients on MS treatments being treated for COVID-19 is very small, and we won't get the information on that for some time. Just a word to say that the MS register is collecting information on patients. If you have anybody who is COVID positive, tested COVID positive, who has MS, they would like to know about it, and I'm sure the Academy can send out the link for that research. A lot of these therapies aren't approved therapies in this country, so I'm guessing this question might not have come from the UK. What I can do is actually just ask our local MI to run a search. It won't be a difficult thing to do, to see if there are any recognised interactions between those drugs, and then we can post that on the site afterwards. But I would say the other good place for following cases of MS and COVID-19 is Twitter. If you are on Twitter and you follow hashtag MS COVID-19 MS, the right way around, or MS COVID-19, COVID-19 MS, and there are case reports going on there all the time about people mostly successfully being treated for COVID-19 whilst on therapy. So that's a positive message.
Okay, excellent. There's one more question to address, and this is that some patients are contacting us that are not high risk in the MS sense, because they're on platform or low risk therapies, but they are high risk due to other comorbidities. And they're asking us to write to their employer to say they need to be off work for 12 weeks. What do we do?
I mean, we have to be practical about this, and a lot of services are running on less staff, or in fact some have none left. And I think if they're having to self-isolate due to another comorbidity, then they either need to go to that specialist team or back to their GP. You know, I always want to help patients as much as I can, but we have got to look after our own patients and prioritise, and therefore I think this is one for another team.
Okay. Ray, anything to add to that?
No, I would agree, and that's what we've been saying to patients who've contacted us. Your MS does not put you at risk. If you have concerns about other comorbidities, you need to speak to your other specialist or your GP.
Okay. So I'm now going to wrap this meeting up because we are over time. So Sarah and Ray, do you have any final comments or statements or advice that you'd like to make for people?
Well, I don't know if it's advice particularly, but I would just say that to make sure everyone is also looking after their own health, you know, making sure they are having breaks. I know a lot of us are working long hours above and beyond, and you know, this is going to go on for quite a long time, I think. So I think we just need to be mindful of looking after ourselves as well.
Right?
Yeah, absolutely. Look after your teams, look after each other. I would say just think a little bit outside the box. If you're struggling and you need help within trusts, there are a lot of people being redeployed. There are a lot of non-clinical staff looking for things to do actually that can be helpful. Speak to your business managers. Things like calling all of your patients on a drug to give them advice. If you script it and you train them to do that, there's no reason why you can't look outside your own teams for help.
Yeah. Okay. So I'd just like to finish by saying thank you to Ray Dorsey-Campbell and Sarah White, to the MS Academy, and particularly Sarah Gillett for all their support here. I think this is providing a really, really useful format for all of us to provide us with confidence and information and a referenceable process in what is an evolving and very, very difficult area. And I would agree with the comments made about we can't treat people if we don't look after our own health. So thank you all very much for participating, and we hope this was valuable for you. Goodbye.
Thank you.
Thank you very much, everybody. Take care.